It mostly starts off as a viral infection and then it becomes a superactive bacterial infection, the most common bacteria being Streptococcus pneumoniae, Moraxella catarrhalis and Staph aureus. Hello everyone, my name is Dr. Umalakshmi. I'm a consultant ENT surgeon and today I'll be taking a very important topic for you called acute sinusitis. So let us see the key words in this particular topic first. You should know about acute sinusitis, the types of sinusitis, how you diagnose it, its medical treatment and also its surgical management. So these are the things you're going to study today. Let's take up a case scenario at first. Suppose a patient presents with a history of a right-sided facial pain with nasal obstruction and purulent discharge from the right nostril, and on examination he has a caries of the right upper molars. He is diabetic with a very poor control. What could be your most probable diagnosis? Let's look at the definition of sinusitis. It is an acute inflammation of the paranasal sinus mucosa, which is most commonly in the same order: maxillary, ethmoidal, frontal and sphenoidal. This is the usual order of the frequency of the sinuses involved. There can be an entity called multi-sinusitis when all the sinuses which I mentioned before are involved, and pan-sinusitis when each and every sinus, including the sphenoid sinus, is involved. And there is also an entity called open sinusitis in which the secretions come out of the nasal cavity, and closed sinusitis when it is confined to the sinuses and hence will be severely painful. Let's go to the next one. What is most common etiology? Nasal infections as a part of rhinitis, because rhinitis is very closely related to sinusitis. Swimming and diving into infected and chlorine related water, trauma to the sinuses, and as I told you earlier, dental infections. Now let us look at the predisposing factors. You must know this. There can be local factors like obstruction of the sinus drainage and ventilation, which causes stasis of secretions, nasal packing causing nasal obstruction, deviated nasal septum also called DNS, vasomotor rhinitis, nasal polyposis and hypertrophic turbinates. Let us look at the local causes to be continued. The stasis of secretions in a cavity due to some conditions like cystic fibrosis and adenoids and a previous attack of sinusitis. Let's go to the general causes, which include environmental causes, poor general health and immunocompromised states like diabetes mellitus, which is very common, and AIDS, which is relatively less common. Let's go to bacteriology. It mostly starts off as a viral infection and then it becomes a superactive bacterial infection, the most common bacteria being Streptococcus pneumoniae, Moraxella catarrhalis and Staph aureus. And there can also be anaerobic infections, which are more common in those anaerobic states and also in those states in which there is immunocompromise. Let's look at the pathology. There is an acute inflammation, there is exudation of fluids, polymorphonucleosides, and increased mucosal secretion. First it becomes urulent and then it becomes fiercely purulent. Dental infections are usually related to maxillary sinusitis because the molars, the upper molars are highly related to the floor of the maxillary sinus. Let's look at acute maxillary sinusitis. As I told you earlier, the commonest sinus to be affected by sinusitis is your maxillary sinus, followed by ethmoidal, followed by frontal, and finally sphenoidal. So let's go to acute maxillary sinusitis. The clinical features and constitutional symptoms include headache, fever and facial pain, tenderness, nasal discharge and nasal obstruction. Postural test which will show a discharge in the middle meatus. So this is the inferior turbinate and this is the middle turbinate. This is the middle meatus, this is the inferior meatus. Discharge will come out of the middle meatus, which especially when this particular sinus is turned up, so it will be a dependent kind of drainage. And what you can get is a very common entity called post-nasal drip or PND. Hope you have understood that. Let's go to diagnosis. Earlier we used to use transillumination tests using torches. We use X-ray PNS or the paranasal sinuses, in which you have a typical view called the Waters view, in which you can see almost all sinuses through the open mouth. CT scan very rarely. The treatment includes antimicrobial antibiotics, decongestants just to increase the flow so that the obstruction of the meatus is opened, steam inhalation, analgesics to reduce the edema and the pain, and hot fomentation to give a symptomatic relief. The surgical treatment is very rarely done. You do an antral lavage, which was done at an earlier stage, and functional endoscopic sinus surgery is usually not done in cases of acute sinusitis, because in case of acute cases, it is always better to avoid surgical procedures because of the problem that there can be increased vascular flow. Complications of maxillary sinusitis include chronic maxillary sinusitis and acute maxillary sinusitis, subacute, osteitis, osteomyelitis of the bones, orbital cellulitis, because if you look at it, the roof of the maxillary sinus is intimately related to the lower or the floor of the orbit, and orbital abscesses, which are all these are more common in immunocompromised states. Let's go to the next type of sinusitis called acute frontal sinusitis, in which you have got the etiology usually follows a URTI, upper respiratory tract infection. This can also occur after swimming or diving. It can also be because of external trauma and secondary to other sinus infections. The clinical features being frontal headache, office headache, tenderness of the frontal sinus area, that is exactly between the brows, in between the medial canthus and just below the brows. Edema of the upper eyelid can occur, a suffused or a red eye, and nasal discharge. I have just given you a radiology of the X-ray, in which you can see the orbital shadows. You can see the frontal sinus, which are usually asymmetrical. It is clear in this case. The inverted pyramid shaped maxillary sinuses, and through the open mouth, apparently you're supposed to be seeing the sphenoid sinus. Other things are also marked here. Medical management of all sorts of sinusitis is almost similar. You give antimicrobial agents or antibiotics. You give analgesics. You cannot wait for the discharge to be cultured in order to give an antibiotic, as in the case of other places. You will have to start a symptomatic relief in the form of antibiotics, which are a wide spectrum or broad spectrum antibiotics like Augmentin. You have to give analgesics. You have to give oral as well as nasal decongestants, and you have to give a very good steam inhalation. Surgical treatment, as I told you earlier, in the very olden times, they used to use trephination of the frontal sinus, in which a 2 centimeter long incision was done in the supromedial aspect of the eyebrow here. And the floor of the sinus is exposed. It is drilled, pus is sent for culture sensitivity, and you irrigate with saline and you give an antral lavage. The complications, as I told you earlier, are orbital cellulitis, because even the frontal sinus is intimately related to the orbit, if you look at it. Just like the maxillary sinus and the ethmoidal sinuses, the frontal sinus is also intimately related to the orbit. Osteomyelitis of the sinuses, meningitis, extradural abscess, and chronic fungal sinusitis in rare cases. Let's go to the third type of acute sinusitis, which is acute ethmoidal sinusitis, in which it is normally associated infections of other sinuses. It is usually seen more in infants and young children. The clinical features being pain, edema of the eyelids, nasal discharge, and swelling of the nose. Its treatment, just like in other cases, is analgesics for edema and pain relief, antimicrobial antibiotics, usually broad spectrum, nasal decongestants like oxymetazoline and xylometazoline. Oral decongestants can also be given along with steam inhalation. Again, the complications include similar ones: orbital cellulitis because of its very close proximity to the lamina papyracea, abscesses, visual deterioration, cavernous sinus thrombus in rare cases, extradural abscesses, meningitis, and encephalitis. Very, very rarely you get acute sphenoidal sinusitis. Isolated sinusitis being very rare. It is usually associated with pansinusitis and can also be associated with posterior ethmoidal infections. The clinical features include headache, which is occipital or vertical. It can be referred to the mastoid. You can get a postnasal discharge, which can be seen on posterior rhinoscopy, which is done earlier. X-ray can show a fluid level, and its differential diagnosis includes mucoceles as well as cystic lesions of any of the sinuses. Now let us quickly look at the MCQs. It's a small topic. The MCQs are limited but very important. Office headache is typical of sphenoid, frontal, ethmoidal or maxillary. The answer is frontal. Typically it occurs when the patient wakes up, it will be okay. After some time, because of dependent drainage, he starts getting headache while he is working. The next step is, which is a modality use of treatment, acute sinusitis, analgesics, antibiotics, oral decongestants, nasal decongestants, surgical treatment, which is very, very rarely done because surgical treatment can lead to inflammation, increase in blood supply, will lead to an increased blood flow, and hence we try to avoid that.
Docemy.